Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I am with Jonathan and Frank. How are you guys doing today?
Fantastic,
Doing well.
thank you.
Thanks for asking, Dennis.
Perfect. So, kind of customary for first-time guests, kind of go around the room and just do a quick introduction of yourself. So, Jonathan, if you wouldn't kick us off.
Sure. Jonathan Liu, 20-year retired Special Forces medical sergeant and team sergeant, coming out of the 1st Special Forces Group. I'm currently out in JBLM, Washington, focused now on health issues that pertain to our community.
Perfect. Frank, how about you?
I'm Frank Stadler. I'm the director and founder of MedMag Labs. We seek to commercialize and deliver maggot therapy globally and in Australia, here where I am. I have a PhD in the supply chain management for maggot therapy and have held a grant with humanitarian grant challenges in Canada.
Okay, perfect. So, Frank, if you wouldn't just start off, this is not the first time I've ever heard of maggot therapy. Other than obviously the title, like, why on earth would I put maggots into a wound?
Yeah, maggot therapy has been around for thousands of years. In fact, we have records of the Mayans and the Niemba people of Australia using maggot therapy as a traditional medicine. We have also other records from the war setting, dating back to the Battle of St. Quentin's and Napoleonic Wars, and also the Confederate Civil War in America. And there it was the surgeon Zacharias who first used maggots as a proactive treatment for wounds. In previous campaigns, the war surgeons noticed the beneficial effects of maggots in a chronic wound or in an infected wound, but did not make that jump into treatment. Zacharias did, but then it fell by the wayside afterwards. When William Baer went to the First World War, he was a podiatric surgeon from Johns Hopkins in the US. When he went to the First World War, he saw, again, the beneficial effects of maggots in wounds. And he took that experience back to Johns Hopkins, where he then established a maggot production and treatment program, the first modern medical program of that kind. And it then took off in the 1930s and 40s and became very popular in America and Europe. But then with the advent of antibiotics, it fell again by the wayside and was forgotten. And in the 1990s, 2000s, the last 30 years now, it has gained popularity again because of the high wound burden and the antimicrobial resistance problems we have now. So the reason why we would put maggots onto a wound are threefold. Maggots are designed to eat necrotic tissue. That's what they do in nature. So they remove the necrotic tissue from the wound. But by doing so, they also put digestive juices into the wound, which have antimicrobial properties. They also consume a lot of the microbes in the wound and digest them, and therefore remove them from the wound. So they have infection control properties in addition to the debridement properties. And lastly, their excretions and secretions have also growth factors and hormones in them, which promote the growth of new wound tissue, granulation tissue, and blood vessels. So they promote wound healing as well. So there are very few treatments, I think probably none, that has those three properties in one package, in one therapy. So there is plenty of reasons why we should use maggots.
Okay. I mean, it's being used currently in hospitals. like somewhere in the world, I'm sure, right? Like what conditions or why would I do that versus like just pump them full of antibiotics, do serial wound debridements, honey dressings. Like there's a wound vacs. There's a myriad of techniques to get this done. Of all of those, why maggot therapy?
For a start, maggot therapy can be provided affordably and cost effectively, especially in low resource settings. So this is a major point of difference to other wound treatments. And keeping in mind that chronic wounds are a severe healthcare problem, despite all the other modalities that you just mentioned. So what happens in a chronic wound is that often you have the biofilm development, which renders the wound immune to antibiotics and other treatments. Surgical debridement is very coarse and very imprecise, and often people revert back to the chronicity in the wound. So maggot therapy has been shown to be very successful at kicking a chronic wound into the healing cascade, and therefore not reverting it back to status quo as other modalities often do. So you go away, you debride in various ways, and a few weeks down the track, the wound is back where it was. This does not appear to happen with maggot therapy. In maggot therapy, the wound is actually pushed into that positive healing cascade and develops and heals, starts to heal and not go back.
Okay. So I guess currently, patients like with diabetic necrosis of wounds, I would imagine they're probably a big candidate because you can just pump them full of antibiotics and essentially you're just doing serial debridements until they lose the extremity. And then you move on to the next. Okay. So, are there any reasons why, understood like the necrotic part of it, but is that the important part of it? Because say I have a fresh blast injury or a badly mangled limb where that the perfusion isn't going to be the greatest. Is there any benefit to early maggot therapy, or do we try the others, and when that fails, then we try maggot therapy?
Well, I'm a believer of earlier maggot therapy rather than later, not waiting for it to become a problem, the necrosis or the infection. Of course, you would need to treat the wound first to make sure it's stable and the patient is stable. And if you can afford to cover the wound up for a couple of days, which is required with maggot therapy, then by all means, try maggot therapy. Not only does the maggots debride the wound, but also they provide this prophylactic infection control when they're on the wound. So in the austere setting, that would help to maintain the patient in a good state and the wound and prepare the wound for future grafting or other interventions, while the patient is out of reach of surgical care, for example. So to my mind, maggot therapy should be used earlier rather than later.
Okay. So obvious, we just talked about like diabetic ulcerations, blast injury, penetrating things. What about things like burns? Has maggot therapy ever been used on burned type patients?
Yes, absolutely, with very good success. Maggots can maintain again a good infection control on a burn, which is always a problem with burns. Also, the debridement effect is there. And when maggots, and we haven't talked about that yet, but when maggots can be placed into a mesh bag, they don't need to be directly on the wound. So there's two modalities. One is where the maggots are placed directly onto the wound and have access to all the parts of the wound. and the other is where the maggots are sealed in a mesh bag, pretty much like a tea bag. And when that is the case, and that tea bag is then placed onto the wound, the mechanical impact on the wound is not as great. So in burns, you have the pain issue, and debridement of burns is very painful. So having the maggots placed onto the burn in that bag would alleviate much of the pain issue. There will be still some, but not as bad. And so any maggot therapy is not only indicated for wounds that are chronic, there can be also acute wounds that require debridement, like a burn, for example.
Oh, perfect. So, Jonathan, obviously, my guess is you're looking at this from a more austere perspective, which I think is always wise. I guess what brought you to this, and what do you think now that you've been kind of delved into it?
Sure. So I got brought into this actually because I got very, very interested in what to do with what are we going to do with some of the really big problems we're looking at, specifically when we're looking at the Indo-PACOM theater. So I just spent the past 2.5 years or so as the senior enlisted medic for First Group. And the majority of those 2.5 years was running around Indo-PACOM, throwing up red star clusters and red flags up saying, we need to start looking at this supply chain issue that we're going to have. Because the fact is that it doesn't take a whole lot to disrupt the health service support supply chain. We saw that very recently during the pandemic. We see it currently right now with national ketamine distribution, just because a tornado hit one single factory in the United States. You compound that now with 70 to 80% of our antibiotics are made internationally, and the precursors to many of the world's antibiotics, 70 to 80% of those, it's estimated, are made in China. That creates a huge, significant national security issue for us, and especially for us here in the special operations domain, because we're expected to be operating maybe 360 days, 180 days prior to the arrival of any kind of conventional forces. So as everybody is amassing out and trying to create, packages for Class 8 and preparation for large-scale combat operations, is it a realistic expectation for there to be enough antibiotics for SOF to carry in, but so far left of actual escalation force? And that was the problem that I was looking at. There's no way that we can expect that to happen. And the other piece of that is that there's just going to be massive casualty counts. I think gone are the days of concentric circles on a map depicting golden hours. I think the question now is no longer, how do I get my guy out, my injured casualty out and evacuated and sped to the rear? I think the question that we need to be asking now is, how do I keep my guy alive, my casualty alive, until the frontline trace comes back to me and the big green conventional machine meets us and we get reunited with the friendly lines? And that could be a very, very long time. So that I ask to any soft medic operating out in austere environments, how much antibiotic do you actually have? How much are you expected to be able to have in possession, and how are you going to use that frugally to be able to ensure that you do the most good for the most people? It's not like we're creating any more antibiotic once we're out in our area. Yeah. And I thought what was beautiful about maggot therapy was that, the particular fly species that we're looking at bottle flies, green bottle flies, is endemic in virtually every part of the world that we're operating in. And the ability to be able to simply capture, clean, and raise maggots for this purpose is something that we're just not going to be able to do to any kind of scale with antibiotics per se. So in a way, it is kind of a force multiplier for health service support and for Class 8, if you would, because we can take it from where we are and create it and be able to leverage that to potentially affect the outcomes of our future casualties in a large scale combat operation scenario.
No, that makes 100% sense, especially when you're talking about, obviously, we're talking about trauma injuries or some kind of penetration or burns or something like that. I don't think maggots are going to help with leishmaniasis or like dengue or something like that. But at least if you can reduce the burden and the amount that you need, extend what you have, it's always a smart choice. So that was another question I had is, like, can I just get random flies? Does it have to be a specific fly? I imagine bot flies are probably not a great choice.
Probably not. No. I actually did an experiment while I was in the Philippines earlier in 2023, and I was able to utilizing a protocol that was actually collaborated on with Frank and a colleague to locally procure materials necessary to catch the specific fly species that we were looking for. And it's a green bottle fly. The species of it eludes me. The actual binomial nomenclature of it eludes me at this point. But I was able to actually procure. Yeah. I was actually able to procure this particular fly and get it to lay eggs and get maggots out of it, all within the course of maybe 3 attempts of trial and error. So a little bit of a learning curve, but we're not talking about a learning curve of it. This took me 6 months to perfect. This was a side project that I would go and check on over the course of a week and a half. And I had a viable source to be able to continue on, clean these maggots and potentially utilize them for future patients.
So the green bottle flies, are they the only kind of flies that are utilized, or are there others? Or
yeah, I would defer to Frank on that one.
Yeah, please, Frank.
Yeah, so fortunately, we use caliphorid flies. That's a shorthand for flies that specialize on necrotic tissue and cadavers. So they don't feed on live tissue. As you mentioned, the botfly or the screwworms, we don't want them because they feed on live tissue. So fortunately, those caliphorid flies are very widespread. There's 1 or 2 or 3 species that we know of in each of the biogeographic regions in the world that we would have access to and could utilize. And these are only the ones we know have been used already and have been documented in literature, in the papers. There are hundreds of more species out there that are potentially useful. And when you go out and source your material for maggot therapy in the austere setting, you can easily start with a piece of rotting meat, put it out there, let the flies come, and most often, or more often than not, the flies attracted to this particular meat will be those that are also beneficial in a medical setting, because they are specialized and attracted by necrotic tissue.
Okay, so that's essentially how you catch them, right? Just a special. If you want necrotic tissue type flies, then put necrotic tissue type bait out, and you collect them. Now, I've trapped them in a jar with my rotten meat. How on earth do I clean these? Do I even need to clean the fly, or is it the maggot that's important?
So in a modern setting, in a modern Western clinical setting, one would expect medicinal maggots that are germ-free or largely germ-free. We achieve that by harvesting the eggs of the flies and surface sterilizing these eggs with chemicals. And then the eggs are then reared for a day or 2 on a sterile medium. And that ensures that the whole life cycle up to that medicinal maggot is sterile. and the maggots that are placed onto the wound are largely sterile. In the austere setting, this is not always possible. We have developed a very simple methodology for ensuring high quality and largely germ-free maggots in the austere setting. We have done that as part of our humanitarian grant challenges grant. We call it the DIY lab, so do it yourself. And when you do this, you can get very high grade maggots that are safe to the patient. Stepping back into even more austere settings where you don't have access to the materials we have used, it is possible to use undisinfected eggs or very young maggots of a known species or of a species that is effective. However, the risk is there, a minute risk is there that you would get additional infection in the patient. But it is a very small risk, and anecdotal and documented cases of accidental fly infestation in people. We call that myiasis. Accidental infestations routinely lead to very good health outcomes in patients. There have been documentations where people were lying with an open skull fracture in a ditch for a week and were then infested by maggots. And what normally would lead to a certain death within a couple of days, the maggots maintained a systemic health of the patient, and after removal of the maggots, the patient was fine without any brain infection, without any other negative impact. So, and there are a number of cases like this that demonstrate to us that medicinal maggots or maggots in general, when found on a wound in the wild, are quite safe in most cases. So, to answer your question, we can use what we've got. Ideally, we deal with really sterile and clean maggots. But if we don't have that available to us, then we can use a lesser quality as well.
Okay. And I mean, like you mentioned, the infections that, say you did nothing, you just threw a piece of meat out there, you grab some flies, whatever maggots happen to be there as well, and we use that. The infections that did happen, even if they're just anecdotal instances, were not life-threatening. You know, we're not talking sepsis. We're not talking life-threatening.
No, we have talked about William Baer earlier on, the surgeon from the World War I. When he came back to Johns Hopkins, he tried first treatment with less sterile maggots, and he had some difficulties with Clostridium, and so he then went and surface sterilized his eggs and maggots, and that fixed the problem up nicely. In the austere setting, I am not personally aware of any of these reports on myiasis that have indeed resulted in a fatality. So most of the reported cases, they report them and say, "Oh, how awful! There were maggots in the wound. We removed them. The patient was good, was happy, but they haven't reported on a maggot therapy leading to fatal outcomes. Indeed, they have to usually admit that the wound looks really good after they have removed the wild maggots from the wound."
Okay, very good. So, you know, I've caught my flies. I've got the maggots as clean as I possibly can by whatever mechanism I have found. How do I do this? Do I just drop them in the wound? How many? Is there a certain number per size of wound?
So usually we use around 8 maggots per square centimeter of wound. That is, but a few more or less is not a drama. If you use far too many maggots, then you might have problems with pain. The patient will notice more pain, or with excessive numbers of maggots, the patient might have elevated ammonia levels, because maggots, when they excrete into the wound, they excrete ammonia, and that raises the pH, which is good. You want that because it controls infection as well, the higher pH level. But it can cause trouble. But this is very rare and almost unheard of, because you would need thousands upon thousands of maggots in the wound for this to be a problem. Maggots, as I said before, we can put them directly into the wound. We call that free-range application. And if you do that, then you would want to create a cage dressing on top of the wound so the maggots stay in place for the 2 or 3 days that they're in there, and do not run away into the healthcare environment. Of course, in the austere setting, that might be less of a problem rather than in a hospital setting, but it is still preferable that you have control over your maggots, and that's why we do this cage dressing. Alternatively, you can place them into a mesh bag, and then you don't have all these problems. It's very simple. You place the maggots onto the wound in the mesh bag, put gauze dressing around it, and that's it. With both treatment modalities, you would have to control the exudate from the wound. When maggots are in the wound, you would tend to be wet and exude. And so you capture that with an extra gauze dressing on top and replace it regularly. And after 2 or 3 days, you take the maggots off and replace them if needed. If there is a further requirement for debridement and infection control.
So the dressings that we put on, you mentioned a cage dressing, is that like a wet to dry kind of dressing, where you're just essentially covering over the wound and having either some kind of ACE wrap or tape it in place? Like, how do you get this cage dressing?
Yeah, so cage dressings can be as simple as a piece of fabric, a shirt sleeve, for example, taped around the extremity and taped to the skin so that the maggots stay in place. Or there can be a high-tech mesh dressing, a nylon dressing that is taped to the peri-wound area on top of a barrier of hydrocolloid tape. So you place the hydrocolloid around the peri-wound area, place the maggots into the wound, and then tape this mesh dressing, that mesh, onto the hydrocolloid to form a maggot-proof barrier that they can't escape but still can breathe through the mesh. We have guidance on how to apply mesh, free-range and bagged dressings. You can find them very easily on our website. You might want to share that later on with your community.
Yes.
And also there's guidance in our book which we have written, the Complete Guide to Maggot Therapy. It's an open source book that anybody can download from open book publishers, and there's all the guidance that your community needs to learn how to apply medicinal maggots very carefully and safely. And at this stage, I might also add that we're running a lab at Summer 2024, specifically to the point of how the supply chain management for maggot therapy is achieved in the austere setting, and how soft medics can treat patients in the austere setting as well. And there, participants will be taught how to apply and remove maggot therapy dressings in the austere setting. So it's on May 13 at SOMA 2024. We run that lab. And
Perfect.
We're joined by the eminent expert in maggot therapy, Ronald Sherman from the Biotherapeutics Education and Research Foundation, also based in the US.
Perfect. So other than the free-range maggots, you mentioned you can put them in a bag. Is there any reason why you would do one versus the other?
Primarily, it is convenience and patient and medic acceptability. So producers in the West, in the modern setting, have found that they have more commercial success when they place maggots into a bag, and so they're out of sight and and easy to remove at the end of the therapy. So it's convenience, but if you're after fast and effective treatment, then free-range maggots in the wound, directly in the wound, is far superior. And it makes sense. They have access to all the nooks and crannies, the undercuts in the wound. They have access that they can use their mouth hooks. So maggots do not have a chewing mouth part like a beetle, for example. They have to liquefy their food in the wound before they can ingest it. And the only means of mechanical loosening of that necrotic tissue they have is two mouth hooks that they use, sort of probing in the wound tissue, which they cannot do as effectively when they're in a bag. And also, their body is covered in the tiny microscopic spines, and their movement across the wound also aids to the loosening of necrotic tissue, and also the interruption or disruption of the biofilm in there. So from a therapeutics point of view, free-range maggots are always superior, but from a marketing and sales point of view, the bags win out in the Western setting.
Okay, yeah, that 100% makes sense. I would probably freak out if I woke up and there was a bunch of maggots in my cut. So you mentioned you're going to leave the maggots in the wound for a couple of days, 2-3 days, I think you said. So when it comes time to remove them, are you just removing them and 1,000 flies are coming out of it, or are we just picking these out because they're in another stage?
So maggots will not continue to feed beyond 2 to 3 days. So when they have reached their late third instar or late third stage of development, then they want to leave their food source and pupate into a fly. And basically, the hungry caterpillar kind of metamorphosis kind of process is happening.
Yeah.
And so you will never have a maggot stay back in the wound. So they, after 2 or 3 days, when they're satiated, they want to be out. And we utilize this when we remove the maggots. They're quite willing after 2 or 3 days to come out of the wound, and then the dressing is opened, they're wiped out and irrigated out, and then the wound is assessed and continued with treatment. The maggots then go into clinical waste stream that cannot be reused for breeding or anything else, or for further treatment. It's impossible. So they become clinical waste and go into waste stream.
Okay, very good. And then I imagine, like you mentioned, once this first couple days of treatment is over, you essentially reassess the wound. How many? Obviously, it's going to depend on how bad the wound was to begin with, but on average, if there was one, how many treatments are generally required?
So some patients respond with one treatment, but usually it's 3-4 treatments successively. So over a period of 1 to 2-3 weeks, even the most necrotic wounds see very good results. So that is, the treatment, of course, is about 2 to 3 days. So you get about 2 treatments into a week. if you do that successively. But around 3 to 6 treatments will clean up most wounds. Yeah.
Okay. Perfect. Now,
But I should also add that even beyond complete debridement, many researchers these days, many advocates say that it is beneficial to continue using maggot therapy for those other benefits that we have spoken about, the infection control and also the wound healing properties that they have. So those benefits last beyond the debridement, and therefore there is merit in prolonging or repeating treatment beyond complete debridement.
Okay. Now I imagine just like most treatments, especially when it comes to wound management, generally the treatment regimen is kind of a hybrid of other techniques, right? So do you think it would, again, let's try and be on the same page. We're talking about like a blast injury, right? Some like at the ankle, everything underneath it is just kind of mangled mess. Is it common maybe in wherever it is to do maybe like a debridement, take the majority of things that you know are dead and are not going to be salvaged, take that off, and then use something like maggot therapy to kind of clean up what couldn't or wasn't debrided off, and kind of clean up the last bit of problems, and then just kind of continue that treatment so it doesn't get infected worse anyway?
Yeah, look, John, how would you normally approach a wound like this in your current approach to wound care in the soft arena?
Sure. In the soft arena, if it doesn't look like it's salvageable, then more than likely we would be taking out anything that doesn't look like it's viable to begin with. From there, we would continue to take until it was very, very clear that there was no more, that the rest of this issue was viable, and then initiate a delayed primary closure protocol. In there, it's continue to do that in that manner. Antibiotics is a large portion of this protocol, and that I think that in itself is worth highlighting in the case too, because really what we're pitching is an alternative adjunct to antibiotics, or in the absence of antibiotics, can we incorporate MDT or maggot debridement therapy in lieu of antibiotics for a delayed primary closure? And I think that's where the institutional knowledge is kind of there's a gap in it right now in terms of the knowledge, skills, and abilities of our soft medics as they come out of the schoolhouse, and this opportunity, which I think everybody would generally agree there's probably some viability to MDT as a means to improve health outcomes. So really, what I would consider is how would we, one of the major problems to implementing this and getting a lot of buy-in by and large would be to how would we address that gap right there? How do we get into the institutional knowledge and kind of rewrite some of the protocols that are being taught within the Joint Special Operations Medical Training Center? I believe it's CPG 62, the acute wound care piece, or the acute wound care clinical practice guide there. I think I lost you for a second.
That's
Got
all
me
right.
back?
Yep. No, yeah, I think you're 100% right as far as getting the therapy in. I think we also kind of, I wouldn't say take a realistic look. But
what I was proposing
holistic,
was that we could potentially use the
What,
clinical
what
practice guides
Frank and
as
Jonathan
a
both, what you
model to
described as
get
far
this
as,
information out there
extremity
to
injuries
soft
makes
medics,
100% sense.
and so that they
Like,
can
absolutely.
replicate some of the process that we had. I am by far and large not the handiest man in the world, but with a 2-page scribble notes protocol, I was able to replicate the process for capturing and raising a viable maggot source, all within my spare time while out on a JSET. So
Yep.
I posit that if we can get some buy-in from the institution to consider this as a viable means, in the absence of the best course of action, which are of course antibiotics, how then do we build those KSAs in our population so that they can feel comfortable raising maggots, and it just becomes second nature to them, much like water purification or some other menial task that the junior 18 Delta would be executing on a team.
Sure. How do you do it? You get them to do it. That's the simple answer, is they have to learn how to do it and actually do it. But I think we also got to be at least quasi cautious about is if it's put forth as you can do now without antibiotics, that's a danger, because with a complex injury, you have penetrations to the abdomen into the thorax. I don't know lots about maggot therapy, but I'm guessing you probably don't put them into the abdomen.
Well, I think
maybe you do.
Yeah, you could if you were certain that they don't go places where they shouldn't go. So in the case of an open cavity, you place them into a bag and then you have control over the maggots. Besides, maggots are air breathers, and they, as I said, they want to be out of the wound by day 2 or 3, and so they will naturally migrate again out of a cavity or a sinus. So that's not so much an issue. Back to your question around whether maggot therapy merits in the setting in various etiologies. And maggot versus antibiotics. Maggots work best when they're treated or used in conjunction with other treatments. So you don't rely only on maggots. In fact, when you use maggots and antibiotics together, they have a synergistic effect. So maggots are actually not impacted negatively by antibiotics or indeed by narcotics either. So the scientific literature into forensic medicine has shown that maggots can operate quite nicely under, with ketamine and other kind of narcotics in the system. But it is important to understand that we do not promote maggot therapy over any other intervention. We want to use maggot therapy as one of many tools, and we believe that maggot therapy is the best first tool to use for wound debridement after, of course, the resectioning or sharp debridement at the very beginning. But for any chronic or infected wound, let's use maggot therapy first and then progress into more standard conventional wound therapies like the negative pressure, etc. It's just that wonderful impact that maggots have onto the wound, kicking it into that healing cycle that the other modalities fail to do.
No, absolutely. And when anybody says, this is going to augment what is current, I'm 100% all ears. And I think you're absolutely right. This could be an augmentation to it. What I would see, I think realistically, to Jonathan's point of what the future may hold, we're probably going to be receiving patients down a line of evacuation, and they probably at some point have gotten antibiotics, either because that's what I was taught and that was my knee-jerk reaction. It was dirty and I assumed that was infected, so I just did it. And now, I'm now receiving the patients, like Invance, you need it every 24 hours. Well, do I do another dose of Invance, or do I do another option and save that Invance for another person who needs, kind of on the spot type coverage, just to get them farther down the line so we can do other techniques? Either Jonathan or Frank, we'll start with Frank. Of what we covered, is there anything that I absolutely missed that we really need to talk about?
Look, I'd like to stress that maggot therapy is entirely possible, and we are able to create a reliable supply chain in even the most austere setting if there is an institutional will to do so. So we stand ready to further research and develop solutions into making maggot therapy and the production of medicinal maggots in austere settings more effective, efficient, easier for the soldier and the medic. And even with existing tools that we have developed, as Jonathan has verified, we can already safely supply medicinal maggots anywhere in the world. Our aim would be to make that more comfortable to the medic and introduce solutions that are more professional and in line with expectations that the military has. But this is down the line. Once we get buy-in, once we demonstrate that there is a positive impact in the field, I think that will come naturally. But in the first instance, we want maggot therapy to be out there, be used in the field, and documented, so that medics document the impact that it has in the field, and then bring it back to the schoolhouse and back to the research and development office with us.
Yeah, perfect. Jonathan?
Yeah, the one thing that I would just want to encourage to the force at large is, this was not a difficult pet project to build a locally procured trap and raise maggots that would be viable for MDT. And it was remarkable to me, after failing twice for simple reasons, like I left the trap too low and a snake got into it, or a goat came and ate my meat. The third time, I had such incredible confidence in my ability and what I was doing that it was almost second nature to me already. And lo and behold, I caught exactly what I needed to and was able to procure what I needed to out of that project. The lesson learned there is that you really just have to take a very hands-on approach to it if you're going to learn how to do this. And it's a whole lot like preparation of the environment. If you're out there on a JSET, figuring out what works, what you could potentially use to be able to fabricate or improvise a specific device that you would need to raise these maggots in the future, document it, write it down, capture that into the knowledge base that you capture it into, so that those that come after you won't spend that curve time relearning the things all over again. And if we continue to do that and we institute a culture of a learning organization as opposed to an individual skills that perish as soon as that individual leaves the organization, I think that we will see MDT here as a viable piece within our tool set as an organization and as an institution into the future.
Yeah, I mean, that goes with just about any lessons learned. If it's not written down and you never told anybody, like, it's not actually a lessons learned, right?
Right.
Cool. Well, thank you guys very, very much. I really appreciate it.
Thanks, Dennis.
Hey, thanks for having us, Dennis.
And see everybody in summer 2024.
Yeah, I'll be there.
Excellent.
For today's podcast, be sure to go to our website, www.prolongedfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy, it's waiting there for you.